Welcome, very big welcome to everybody today. The intention for this, it's only going to be a short preview webinar, maybe about half an hour, depending on how many questions everybody has, because we've been getting a heap of questions about the lameness workshop. So this is our very first in-person lameness workshop held in Ocala, and tomorrow I know that you're coming. I'm excited to meet you in person. It held over 3 days, 5th, 6th and 7th of December, right before the AAEP at the very beautiful Ocala Equine Hospital. So we put this workshop together because of the participants in the program. They kept on asking us, like, when are you doing this? When are you doing this? When are you doing this? And we said, okay, let's put something together. And we've been asking ourselves the whole time, how can we make this even better? And then we get a better version and then we go, how can we make it even better? So what we've settled on right now, pretty excited about. We're only going to give you guys a little bit of information though, because the intention is to surprise and delight the people that come to make this an absolutely incredible workshop. So we thought what we would do for you today is present one of the case studies, because in the real workshop, we're going to have, I think, I should have counted 6 horses, I think, that we're going to be looking up, working up, looking at them for the static and dynamic examination, ultrasound, etc. We're not using live horses for the nerve block cadaver wet lab. That goes without saying, of course. But this is really just intended so you can get your eye in and be familiar with what's going to happen for the real thing. The videos to this are in the Facebook group. So if you've got another device or part of your screen, you can just open up the Facebook group and watch those videos. They're numbered 1 through 4 so that they're not so jerky. Okay, Dr. Dyson, the floor is yours.
Okay, so I'm just going to present a case which I think is representative of many different cases that we all face. And I just want to inspire you. So this is a 12-year-old general purpose riding horse, which has been in the owner's possession for 10 years. And it had a sudden onset of bucking behavior 9 days previously when ridden. And the owner had become somewhat frightened, and therefore she has not ridden the horse since. And so I looked at the horse in its standing still, and it had very sloping hindquarters. And then that makes me ask the question, is this a conformational abnormality, or probably more likely, is this a postural adaptation to chronic pain? Both the thoracolumbar region and the hindquarters were poorly muscled, but the muscle development was symmetrical. There was a firm, non-painful swelling on the distal medial aspect of the left hock, as we can see here. And there was abnormal tension in the lumbar epaxial muscles on the left side. So now we're going to see this horse moving in hand, and I've used audio here, so I'm not going to make any commentary whilst you watch the video, because I want you to both watch and to listen. But what I observed was that the horse showed a short stepping hind limb gait. There was no swing of the tail, which to me reflects a reduced range of motion of the thoracolumbar sacral region. And I asked myself, why? I did hear the audio, and the horse sounded very rhythmical. There was no evidence of a hind limb toe drag. The horse trotted straight. I would have said, being very critical, that the horse showed a grade 1 out of 8 right hind limb lameness. The horse has got a saddle on, and the saddle rotated from side to side or oscillated from side to side. But I would have said that this rotation was reasonably symmetrical to the left and to the right sides. But I want you to compare that with what we see when we eventually see the horse ridden. We didn't observe this in the video footage, but the horse often jumped into trot, so it lurched forwards into trot. And therefore I asked the question, why? And this is generally something that we see because horses don't want to push adequately from behind because they've got hind limb discomfort. And so therefore they lurch forwards as a way of compensating for not wanting to push properly. Flexion tests, proximal limb flexion tests of the hind limbs were performed, and I do this for a minute. And I try to separate out the proximal limb joints by holding the metatarsal region just above the fetlock to compress the hock, stifle, and hip joints. And as I say, I do this for a minute. And I observe the horse during flexion, and I say, is the horse comfortable during flexion? Does it try to fidget? Does it lean away from me? This horse did not lean away from me. It was comfortable during flexion, and there was no change in the horse's gait after flexion. So that gave me no clues whatsoever. And we have to relate that back to the fact that this horse had this firm swelling on the medial aspect of the left hock, and had that reflected a pain-related lesion, I would have expected this horse to show left hind limb lameness after left hind limb flexion. Now we're going to see the horse moving on the lunge. And it's got a rather short stepping gait, both in front and behind. It's a little bit hurried. It's moving its head and neck quite a lot. It tends to look a little bit to the outside. The inside hind limb tends to cross under the trunk during protraction, both specifically on the right rein. A short stepping hind limb gait. The tail hung rather than being swung in association with movement of the horse's thoracolumbar-sacral region, and the inside hind limb crossed under the trunk as it was protracted on both reins, but more on the right rein compared with the left. And the horse had an unsteady head and neck carriage. So it didn't look normal. It did not look like a comfortable horse. Each time when we approached the horse to be tacked up, it went to the back of the box and turned the hindquarters to the handler. And when I questioned the owner about this behavior, it was apparent that it had been present for more than 6 months. When I examined, the saddle fitted very poorly. It sat too far forwards, it was perched, and the tree points were tight. And we previously performed an investigation into the relationship between behavior during tacking up and mounting and the presence of other abnormalities. And we had shown that there was a relationship between abnormal behaviors during tacking up, which includes going to the back of the box when you present the tack, and the presence of either tight tree points of the saddle, the rider sitting on the caudal third of the saddle, or the presence of hind limb lameness. So these observations during tacking up are very important. We had observed that when this horse was lunged with the owner's saddle, the horse immediately shortened its forelimb step length and snaked its neck and head. And you've already seen this horse on the lunge. It was wearing a saddle, but it was wearing an interventional saddle. So what we saw with the owner's saddle was that behavior was far worse. When we removed the saddle completely and lunged the horse, what we observed there was an increased forelimb step length, and the head and neck were more still. So this indicates to me that one of the problems of this horse is the fit of the saddle to the horse. And that's quite important to recognize. So now we're going to see the horse ridden, not in the owner's saddle, but ridden in an interventional saddle in which the horse was much more comfortable. And we can see that the horse has a very quick rhythm. The tail is held absolutely rigidly. It doesn't swing from side to side. It should follow the movement of the horse's back, but the horse's back is held very rigidly. Going on the right rein, the horse is showing a mild right hind limb lameness. The saddle oscillates a little bit from side to side. The horse never really takes a contact, so the reins are slack. And in canter, again, we have a rather hurried rhythm. The horse puts its head and neck to the outside. It doesn't canter particularly straight. It's holding its tail a little bit to the left. The rider is being bounced up and down out of the saddle, and that doesn't normally happen to this rider. This is one of my technicians riding because the owner was reluctant to ride because of the horse's previous bucking behavior. So there was a short stepping hind limb gait in both trot and canter. The horse, to me, lacked hind limb engagement and impulsion. The head was above a vertical position, as we see in the photograph on the right. The horse tended to open its mouth with separation of the teeth. And on the left rein, as we see depicted here, the head and neck were held to the right. So the horse is compensating in its position for whatever reason. If we look at the movement of the saddle, tended to slip more to the right than to the left. And on the right rein, the horse showed a consistent right hind limb lameness, which I would have graded as 2 out of 8. So 2 out of 8 is a mild right hind limb lameness. And we can see that the right hind quarter is dropped more than the left. And we can see that the saddle is slipping more to the right than it is to the left. And we have to bear in mind that the most common reason for the saddle slipping to one side is hind limb lameness. There was mouth opening, and the rider was bounced in canter on the right rein. So you can see here she's sitting in the saddle, but here she's being pushed out of the saddle. And that's because the horse is holding its back with a reduced range of motion. So it's pushing the rider out of the saddle. So how many of these observations did you make watching the video recording? The horse was cantering on 3 tracks on the right rein, so that the right hind limb was not following the track of the right forelimb, but it was on an inner track. So let's now see the horse trotting in 10-meter diameter circles to the left and to the right. So the horse has increased its step frequency. It's more hurried. And this is the spontaneous reaction of the horse to being worked in a biomechanically more demanding movement. 10-meter diameter circles to the left and to the right. We can see it opening its mouth. We can see that the position of the head and neck keeps varying up and down. And the horse tends to bend towards the outside of the circle.
Okay, that's fine.
So there was a varied rhythm. The horse was hurried and then slowed. The head position was unsteady, changing up and down. So here it's down, and here it's up. The horse was more uncomfortable turning to the left and going to the left. Left hind limb lameness was accentuated, such that the horse brought the left hind limb underneath the trunk during protraction and during the stance phase. Also, the rhythm became more irregular on the left rein, and the horse's head became behind a vertical position. And that often happens when a horse is more uncomfortable. The horse either puts its head behind a vertical position, as we see here in the bottom right image, or it puts its head above a vertical position. But it was clearly more uncomfortable turning to the left than turning to the right. So when we think about the behaviors of the ridden horse pain ethogram, this horse showed 8 of the 24 behaviors. It had repeated up and down changes of the head position, not in rhythm with the trot. We saw the head tilt. We saw that the head was in front of the vertical position, particularly in canter. We did see that the head was behind the vertical position in the 10-meter diameter circles, but this was for less than 10 seconds, so this did not count as a behavior. However, the horse did show an intense stare. It did show repeated opening of the mouth with separation of the teeth for 10 seconds or more. The tail was clamped to the midline, and there was an irregular rhythm. So the horse was more rushed in its rhythm in the 10-meter diameter circles than it was going around the periphery of the arena. And it also moved on 3 tracks. And we know that if a horse has a ridden horse pain ethogram score of 8 or more, that unquestionably reflects the presence of musculoskeletal pain. I think it's really valuable to watch horses perform 10-meter diameter circles to the left and then to the right, and then back to the left and then back to the right in rising trot. And what I ask myself every time is, does the horse maintain a regular rhythm? Is the same outline maintained? So does the horse maintain the same position of the head and neck? Does the horse turn equally easily to the left and to the right? I ask the rider, does the horse feel regular? Can they appreciate any difference turning to the left and to the right? And I observe whether or not a hind limb toe drag develops. It's important to recognize that the size of the circle is important. 12 meters diameter is too big. The horse finds that too difficult, too easy, I should say. 10 meters diameter is what is crucial. And they need to be circles, not eggs. And if the horse is performing eggs, one have to say, is that due to the rider's lack of control, or is the horse taking control? And often it is the horse that is taking control because that's what it finds it more easier to do, to perform ovals rather than circles. My conclusions, having observed this horse, were that there was lack of hind limb impulsion and engagement. The horse was very unbalanced in small circles, and there was a change of the head and neck position. The horse tended to slam its forelimbs to the ground in canter. We did not observe the horse bucking, which was the owner's principal complaint, but remember, we did not see the owner ride the horse because she was reluctant to do so. When we observed the horse going around the periphery of the arena, it was a right hind limb lameness that predominated on the left rein. However, in 10-meter diameter circles, it was left hind limb lameness that predominated, being a grade 2 out of 8 on the left rein. So that then raises the question as, where do we start for further investigation? It's clear, anyway, to me, this horse has a bilateral hind limb lameness. We had observed this swelling on the distal medial aspect of the left hock. So the question that then arises is, should we examine the hocks radiographically before we perform any further investigation? But I would say there was no response to upper hind limb flexion tests. And in the majority of horses which have distal hock joint pain, there will be a positive response to proximal limb flexion, which there was not in this horse. We did observe that there was hypertension in the left lumbar epaxial muscles. And my observation over many years is that muscle hypertension is usually ipsilateral to the lamer hind limb. But we've clearly seen that this horse is lame on both hind limbs. We've also observed that there tended to be saddle slip to the right on the left rein. And we have previously documented that saddle slip is usually associated with hind limb lameness, and the saddle tends to slip to the side of the lamer or the more lame limb, hind limb, in more than 87% of the horses. So we've got conflicting evidence here in terms of which is the lamer hind limb. So where are we going to start? Do we flip a coin, or do we say because the horse has got left lumbar epaxial muscle tension, hypertension, and we can see more obvious left hind limb lameness on the small circles to the left, perhaps we start with a left hind limb? But we can argue against that and say we've got more saddle slip to the right, and going around the periphery of the arena, the right hind limb lameness was more obvious. There's not a right and a wrong answer here. You have to make an educated decision. And we made the decision to proceed with the left hind limb. So then where do we start? Now, I always say that hind limbs are potentially dangerous to block because horses can kick. And I want to make use of the clinical evaluation, the clinical information that I've ascertained so far. And on my basic clinical examination, there was no suggestion that we had fetlock, pastern, or foot-related pain. So I elect under these circumstances to block the plantar and the plantar metatarsal nerves using 2 ml of mepivacaine and 1 ml of mepivacaine on the lateral and medial aspects, respectively. And this is what we did in this horse. And this resulted in accentuation of the left hind limb lameness. And that's not surprising to me, because when we perform nerve blocks of the distal aspect of the limb, we're taking away proprioceptive feedback from the foot. There are Pacinian corpuscles in the frog and adjacent to the collateral supporting ligaments of the navicular bone, which feed back information to the horse's brain. And if we block that information, the horse is going to load the limb more normally and therefore create potentially more pain in the painful structure. And that's why I think that sometimes when we eliminate information from the distal aspect of the limb, that may result in accentuation of the lameness if the source of pain is proximal to the site of the nerve blocks. You could also ask, why did we only do a 4-point block when we're taught at vet school that we need to do a 6-point block? We need to block the dorsal branches of the plantar metatarsal nerves. I don't think that's necessary. That just results in more aggravation for the horse. And it has been demonstrated by an experimental study in which fetlock joint pain was induced, and horses were evaluated objectively using inertial measurement units, that adding the dorsal branch of the metatarsal nerves made no difference to the lameness, in addition to what had been achieved by blocking the plantar and plantar metatarsal nerves. So I never do a 6-point block. I want to minimize the adverse stimulation to the horse. A 4-point block is absolutely sufficient. I do believe that these nerve blocks can be performed safely in the field. I assess the horse before I perform the nerve blocks and make a decision as to whether or not I'm going to use a twitch. In some horses, I use no physical restraint whatsoever, but I do believe that a properly applied nose twitch, and I say properly applied with a great deal of emphasis, can make a horse very more tractable and safer to deal with. And assuming that we award the horse after performing the nerve blocks, either by rewarding it with a molasses lick or with food, then we are reinforcing that the horse has performed satisfactorily. I think we have to take precautionary measures. I would wear a helmet. My head, to me, is very important. And with a difficult horse, I would have the ipsilateral forelimb held up with the foot held outside the elbow. But if the horse was a tractable individual, I would not be doing that. I strongly believe that hind limb nerve blocks can be performed safely in the field, assuming that you know what you're doing and assuming that you've got a good person on the head of the horse, and assuming you think about details. Look, in the background here, we've got another horse, so the horse doesn't feel isolated. Look here, there's a post here. So this horse cannot kick me. I'm in a very safe position. So this horse showed accentuation of the left hind limb lameness after I had performed the low 4-point block. So now my next block is going to be to perform perineural anesthesia of the deep branch of the lateral plantar nerve. And I'm going to do this by inserting the needle at the junction between when the plantar aspect of the fourth metatarsal is vertical compared with when it slopes from plantar to dorsal. So I'm going to insert the needle at this site, and the needle is going to be inserted directly horizontally, approximately a centimetre, and I'm going to inject 3 ml of mepivacaine. And this is with the leg in a weight-bearing position. Now, I don't have to do it with a leg in a weight-bearing position. I can do it with a leg pulled forwards or with a leg picked up and pulled backwards, but I'm still going to be using the same site of injection. I'm not going to be reflecting tendons in any way. I'm just going to be inserting the needle from lateral to medial and injecting 3 ml of mepivacaine. I always have 5 ml drawn up in the syringe just in case something unexpected happens. And I assess the horse after 10 minutes. And with this horse, after perineural anesthesia of the deep branch of the lateral plantar nerve of the left hind limb, the horse was sound on the left hind limb and was much more comfortable in small circles, 10-meter diameter circles to the left, and more uncomfortable to the right. So we then could observe that the horse was grade 4 out of 8 lame on the right hind limb. So the right hind limb lameness has been accentuated. I then performed perineural anesthesia of the deep branch of the lateral plantar nerve of the right hind limb, and then the horse was sound and much more comfortable. There was then increased range of motion of the thoracolumbar-sacral region. The horse was more rhythmical and relaxed. It no longer slammed the forelimbs to the ground in canter, and there was no saddle slip. The saddle remained aligned to the midline. So what next? I think it's really important to realize that blocking the deep branch of the lateral plantar nerve is not a suspensory ligament block. It has the potential to remove pain from the distal hock joints or even up as far as the talus. So we then performed intra-articular anesthesia of the left tarsometatarsal joint using 3 ml of mepivacaine using the technique that we can see illustrated on the right. And there was no change in the lameness. I think it's important that you limit the volume of local anesthetic solution that you use, because if you use too large a volume, what effectively you're going to do is bathe the proximal aspect of the suspensory ligament with local anesthetic solution. And from that, you're going to learn nothing. So in this situation, we've got a positive response, the perineural anesthesia of the deep branch of the lateral plantar nerve of both hind limbs. We know this block is not specific, so it's really important that we examine radiographically and ultrasonographically both the hock and proximal metatarsal region. And with respect to ultrasonography, we need to include all of the soft tissue structures on the plantar aspect of the hock and metatarsal region in its entirety. So radiography revealed some abnormalities, not surprisingly so, given the firm soft tissue swelling that we had observed clinically. So we've got some modeling of the distal medial aspect of the talus and some modeling on the medial aspect of the third tarsal bone and the proximal aspect of the metatarsal region. But we really need more information. We need to alter the brightness and contrast of our image, and we need to enlarge the image to properly identify what is going on. So we can see we've got this ill-defined radiolucent zone in the distal aspect of the third tarsal bone. We can see some degree of narrowing of the tarsal-metatarsal joint space, and we can see this spur on the proximo-medial aspect of the third metatarsal bone with overlying soft tissue swelling. But remember, we've had a negative response to intra-articular anesthesia of the tarsal-metatarsal joint. We retrieved synovial fluid, so we're confident that we were in the joint. So whatever we're seeing here is probably not of current clinical significance. Just because we see radiological change doesn't necessarily mean that is of clinical significance. We have to put it together with our other clinical observations. And here we see the ultrasonographic images focused on the suspensory ligament of the left hind limb. And there were very similar abnormalities in the right hind limb. So the suspensory ligament is enlarged. We have no space between it and the accessory ligament of the deep digital flexor tendon. Moreover, we've got a diffuse reduction in echogenicity, not only of the suspensory ligament, but also of its accessory ligament, which extends proximally from its attachment to the plantar aspect of the third and fourth tarsal bones. And in addition, we've got echogenic material between the plantar aspect of the suspensory ligament and the plantar cortex of the third metatarsal bone. There should be an anechoic region, but we've got echogenic material, which probably represents that we've got adhesion formation between the suspensory ligament and the plantar aspect of the third metatarsal bone. And the lack of space between the suspensory ligament and its accessory ligament and the accessory ligament of the deep digital flexor tendon also probably reflects adhesion formation, which is not a good prognostic indicator. In the longitudinal images, we can see that we've got long, linear, parallel echoes in the deep digital flexor tendon. But when we look at the suspensory ligament and the accessory ligament of the suspensory ligament, we see complete loss of those long, linear, parallel echoes. And we also again see echogenic material between the suspensory ligament and the accessory ligament of the deep digital flexor tendon, and between the suspensory ligament and the plantar cortex of the third metatarsal bone. So the likelihood is we've got adhesion formation between both the bone and the soft tissue, adjacent soft tissue structures, which are poor prognostic indicators. So the owner would not ride this horse, and she felt that the horse had been trying to buck her off, whereas she'd owned the horse for 10 years and had never been bucked off before. Saddle fit was clearly not a new problem. We have to think, what causes bucking behavior? Is it saddle or girth pain? Is it thoracolumbar pain? Is it lumbosacroiliac joint region pain? Is it hind limb lameness? Is it rib pain? It could be of any of the above. We have to recognize that bucking can become habitual. If the rider is dislodged, it removes, at least temporarily, the discomfort for the horse. So its bucking behavior has become rewarded. And so therefore it will say, I'll do that again. We also have to recognize that bucking is a major rider safety concern, particularly for amateur middle-aged ladies who don't tend to fall off very well and may have pre-existing osteoporosis. We also have to recognize that pain is usually the inciting cause. And if you want to learn more about bucking behavior, we wrote a review paper describing the various causes of bucking behavior and how we potentially investigate and manage those. So our conclusion was that this horse had bilateral proximal suspensory desmopathy in each hind limb. There were chronic radiological abnormalities of the hock, which were probably not of clinical significance. Because of the radiological changes on the medial aspect of the hock, we did carefully examine the collateral ligaments of the tarsus and did not identify any significant abnormality. And not only was there proximal suspensory desmopathy, but there was evidence of likely adhesion formation between the suspensory ligament and the third metatarsal bone, and between the suspensory ligament and the accessory ligament of the deep digital flexor tendon, which are not good prognostic indicators. So I think whenever we look at a horse, we need to put together all the clinical information. We have to realize that horses adapt to lameness. They adapt by decreasing the step length. They reduce the range of motion of the thoracolumbar region. They increase the duty factor. That's the amount of time that they spend bearing weight on each individual limb. So they load share between limbs, and they reduce hind limb impulsion. And as a result, they lose muscle, and they may develop secondary muscle tension. I think it's clear here in this instance, as it is with many horses, that there's a huge value in observing horses ridden. We need to pay attention to the behavior that horses show when they're tacked up. This horse did not want to be tacked up. It retreated to the back of the box. That's an important observation. There's a basic principle with lameness diagnosis. We need to localize the source or sources of pain by using nerve blocks. And then, having localized the source of pain, we need to acquire diagnostic quality images and interpret them appropriately. I believe we have always got more to learn. We need to keep asking questions. Knowledge and experience are empowering. I think that gives you greater job satisfaction, and you do a better job for your clients and their horses. So keep observing and keep asking questions, and join me in continuing to learn.
Awesome, as always. Thank you. Guys, you can, we've got some Q&As coming in. You can pop your questions in the Q&A. Curious about what brand of saddle you use for your intervention saddle.
That's a very good question. I have a treeless saddle, not because I'm a great advocate of treeless saddles, but they're very useful in this kind of situation, in that a treeless saddle will fit many different types of back shape. And so as a short-term question is, can I improve the way in which this horse moves? The use of the treeless saddle is really very valuable.
Okay. How important is it for the horse to be ridden quite correctly on contact on the bit or on the bit in order to accurately assess the lameness? What if the rider is unable to ride the horse effectively?
That's a good question. I don't necessarily need to see the horse ridden on the bit. I want to see how the horse wants to use its body. It does create a problem if the rider is constantly moving their hands up and down and therefore potentially influencing the movement of the horse's head and neck. And in which case I will ask the rider to grab hold of the mane in order to keep their hands still. If the rider is really apprehensive, so they are restraining the horse, that can create a problem. And if they are really lacking confidence, then I will say, do you mind if you put a more confident rider on board? But by and large, I think you can, by careful observation, see what is related to how a horse wants to move compared with what the rider is creating. And I certainly don't need to see the horse ridden on the bit because I want to see how the horse wants to position itself.
It's a great question because it's very clinically relevant, right?
Yeah, absolutely.
This is what we see in real life. It's all sorts of owners, all sorts of horses, all sorts of levels of ability and confidence and locations even. We don't always have a beautiful arena and flat paved surface. Sometimes we just got to deal with what we're given. Okay, let's pop over for here for a minute. I wanted to take some people through a bit of about the logistics and what you can expect from the workshop. So this is the first time we've put an in-person lameness workshop together, apart from when Dr. Dyson was in Australia mid last year, where we ran a little bit of a mini version of this one. We had to get some photographers in to get some of these beautiful images, but just to give everybody a taste of what was actually in the lameness program. So go into the workshop objectives. We've got 3 main workshop objectives, and the biggest, most important one is so you can gain confidence in your static and dynamic examinations. It is just so important, and I'm sure Dr. Dyson will agree with me, because every time, obviously I've been here for every webinar that you've given for the equine lameness program, have seen you teach this in person, and you spend so much time on this because I feel that people want to come in when they want to learn something new or improve their skills, and they're just going straight for the diagnostics. They're going straight for ultrasound, straight for x-ray, and they forget to use their eyes, they forget to use their hands, and they forget to use their brains. I'm going to be the first to admit, when you were going through that case, if I had seen that horse clinically, I don't work in general practice anymore, but if I had seen that horse and looked at that leg, felt that bump, looked at the swelling and x-rayed that, I probably would have just medicated the joint and put the horse on some sort of other medications. But working through that case, we know that wouldn't have been doing the horse any favors, or the owner. Of course, it's a bit of a waste of their time and money. But having Dr. Dyson there to actually walk you right through this would just be incredible. And one of the comments from when Dr. Dyson was over here in July last year was from a veterinarian who is in general equine practice with a heavier load of sports medicine, and they said that they learned more in that 2-hour session than they have in the last 10 years. And this is a very experienced vet, and I just went, oh, holy moly, that's just incredible. So the second objective for the workshop is to basically improve your ultrasound examinations. We are very fortunate. We're going to have some really nice machines there with a couple of really extra probes, some of the specialized probes, very experienced tutors as well, so they can really walk you right through. And this is very much going to be participant-led. So we have a list of the things that we want you to look at in the ultrasound on our live horses, but if you have a particular interest in a certain area, or when we find areas of interest on the horses that we're looking at for the case studies, let's go and ultrasound that. So it's very much participant-led. We've deliberately kept a very small group because this is for you, and we want it to be for you, not what we think you should do. So there's also that opportunity as well. And then the last one is to perform your nerve blocks and joint blocks with confidence. We're actually very fortunate. We have a lot of cadaver legs. I didn't appreciate how difficult they would be to get in the US, but we have lots of cadaver legs. We've got a whole chest freezer that we're bringing with us, not from Australia, but bringing with us to Ocala. And it's going to be a very small group in here with a really high tutor to delegate or registrant ratio. So you're not going to be there in the back of the room waiting for somebody to help you. You're going to have people right by your side. So the agenda is on the first day, which will be the 5th. We're going to welcome everybody. You'll get to meet all the other participants. We are really fortunate in that we have been offered to take the group on a tour of the Ocala Equine Hospital, of their advanced imaging facility. So they have everything that you can think of. They have CT, they have MRI, they have scintigraphy, they have PET scan. So we're really fortunate to be able to take everybody through those. And you might be in a situation where that is not available for you. That's fine. So you can still increase your knowledge so that if you do have a case that may benefit from some of this advanced imaging, a little bit more about it. We then start with our static and dynamic examination of the horse. We're looking at the first couple of cases, and then we'll be having an in-depth discussion of nerve blocks. And of course, when we're looking at these cases, the horse itself is going to dictate where we go with that, and also the participants. If you have questions, a particular area of interest, that's the pathway we'll go down as well. We'll finish that day with a wine and cheese reception so we can all get to know each other a little bit better. Day 2, we are going to kick off with image interpretation. So we thought it was important to put this one in, particularly for the reason that Dr. Dyson just talked about, showing that radiograph for that case. We need to get better at our radiologic interpretation, right? Just because we see abnormalities on there doesn't mean that they're clinically significant. So we're going to be taking a deep dive into image interpretation. And then we're going to be going through, we'll split into 2 groups, and one group will do the ultrasound lab. So very small groups. And then the other group will do their nerve block lab. And then they'll swap halfway through the day as well. We then have a dinner that night. The next day, we're going to be looking at our next 2 cases, 3 and 4. And I'm really excited to let you guys know that we have worked really hard with this, and we're going to be having a horse that is being ridden in English tack. And we also have a horse that's going to be ridden in Western tack, because we know that so many of you guys have your Western sports horses in your practice, and it's not just the English hunter jumper type. So we've been able to incorporate that into the program. And again, it's going to be delegate led. So where the questions you have, that's where we're going to go. We will be finishing up in time for everybody to travel back to Orlando for the start of the AAEP convention reception. You'll have time to go and freshen up, check into hotels, etc. So you don't have to worry about missing out on any of that. So it is held over 3 days. This is an immersive event where you're going to be dropped into learning all about lameness. We have 20 participants, 20 registrants maximum. So we didn't want a massive group here, and a very high tutor to registrant ratio. And there's some surprises there that we're not going to tell you about until you're actually there. And I know there's a fair few of you in this webinar this morning who've already registered. So the benefits of this really is to get your eye in. And as Dr. Dyson has talked about at length, it's about the static and dynamic examination. That's what it just keeps on coming back to, supported by the diagnostic techniques. So we're going to be putting you guys through some ultrasound. You're going to be able to sharpen your regional and intra-articular anesthesia nerve blocks, and basically improve your lameness examinations and diagnostic outcomes. It can benefit your patients and your owners. The other thing, and Dr. Dyson and I were just chatting before the webinar this morning, that I didn't really think about, is that this also gives you an opportunity to get really great social proof. So if your veterinary practice needs some marketing, you can go and tell all your clients, have some photos taken that you have been studying under Dr. Dyson, who is arguably the most eminent, the most famous equine vet in the world. I'll challenge anybody to find someone else. And that gives great social proof for your clients, and it gives them a lot of confidence as well. And no doubt you'll go back to your practices really enthusiastic, and you'll be wanting to do more and more lameness. And that's the idea behind continuing education, right? It should not be a cost. You should consider it as an investment in your career, because what you learn at this workshop at the time, you can put into practice the very next day. So whenever you get home, you can put it into practice straight away, and you'll have that for the rest of your career. You don't lose it. You don't lose it unless you don't use it, right? You got to have horses to go back to. So we do have some final seats remaining. It is US $2,500 for members of the Lameness program, a little bit more for non-members. And I need to let you know that this is the last week that's available for the payment plan. We'll be closing that off very shortly. I've got a link here that I'll have to put the link in there in a minute, but I'm pretty sure everybody is really just hanging out for me to draw the prize to see who's going to be the winner. But we'll send this out to you on email as well. Okay. As we mentioned, if you are here live, we're going to draw a raffle in a moment. And if you are here live, you get a 50% course reduction fee. So I'm really excited to see who's going to win that. For those of you who were at our Lameness program launch about a year ago, you might have remembered that we had to draw, I don't know, it felt 100 times until we actually got somebody who was here live in the webinar. Once we are full, we are going to close off the registration. So if you are interested, go and have a look at it and see if it suits you and see if that's what you're actually after. Okay, let me share my screen. Okay, is everybody ready? Okay, without further ado, we've got all the names in here. Let's go. So I hope whoever the winner is actually here. So if you are the winner, please say something in the chat so that we know that you're here. Otherwise, we'll redraw it. Liz Plowright. Are you here, Liz? Dun, dun, dun. I feel like we need that countdown music, right? Sue, can you see the chat there? I can't see it when my screen is being shared. Let's have a look here. Oh, yes, I can see it. Okay, 10 more seconds. We're going to keep drawing this until we find a winner. 5 more seconds. It doesn't look like she is here. Okay, Liz, I think that you might have missed out on that. Okay, let's try again. Liz will kick herself right when she finds out. Miranda Abrahams. Miranda, are you here? I'm going to keep a record of how many times we need to draw this. Have a look in the chat. Oh dear. I'm pretty sure that everybody else who's here is actually pretty happy. Oh, she's here. She's here. No, that's okay. You don't have to be coming to AAEP. You still win it. So Miranda, congratulations. You have won the 50% off the course. You don't have to be going to AAEP. So that's absolutely fine. No problem at all. Miranda, congratulations. And sorry to everybody else that didn't win, but I'm sure you got some benefit out of that anyway. Yeah, awesome. Okay, we've got some more questions here. Jenny is asking, are you able to tell us the treatment or outcome for the case you presented?
This horse was treated conservatively because although we often treat proximal suspensory dismorphism in hind limbs surgically, in the presence of adhesions, we know that is a negative prognostic indicator. And the owner was prepared to downgrade her athletic expectations for the horse. So it underwent physiotherapy treatment, it underwent a change in the saddle fit, and the owner was prepared just to use the horse for hacking purposes, so to ride around the countryside rather than having regular lessons. And the horse did fine doing that.
Awesome, thank you. Okay, answered that one. Answered that one. I'm interested in spoiling behavior on the ethogram. Do you see spooking as the only sign of musculoskeletal pain regularly?
The answer would be no. In the majority of horses which have musculoskeletal pain, they show multiple signs. Spooking may be one of those signs, but to see spooking alone, I would always think in terms of why is the horse spooking? Has it lost confidence in the rider? Is there something wrong with the training program? We need to address why, if it's the only behavior being observed, because in the majority of horses which have underlying musculoskeletal pain, they will show multiple abnormal behaviors, not just a single behavior. So whenever there's a single behavior, you have to ask why, and has this become habitual? Has it become a learned behavior? Because the horse has learned that if we remove the stimulus, then it is rewarded. So it's rewarded by spooking, and therefore it learns that spooking is a good thing to do because it doesn't have to work.
They're not silly, are they? Do you typically work up your lameness exams in the field or prefer to have them trailer in?
I really don't mind. I think there are advantages and disadvantages of each situation. In the horse's home environment, they're more likely to show their normal behaviors, whereas some of those behaviors may be obscured if they've been brought to a clinic. In the clinic environment, you can perhaps use your time more effectively, and you may have nicer facilities, but there are upsides and downsides. And I really don't mind. I'm entirely flexible. And I worked in a clinic for many years, but I've also worked in the field. So I really don't mind. The important thing is that if I want to be performing nerve blocks, that I'm going to have somebody on holding the horse that I have trust in, that they're going to be able to warn me if the horse is going to show any adverse behavior, which may be a danger to me. And sometimes that person is not ideally the owner, because the owner may be being hyperreactive and have an adverse effect on the horse.
Mm-hmm. And also very interested in watching what you're doing instead of actually watching the horse.
Yes.
Yeah. Or holding the horse at the end of the lead rope. So we've got another question here. Did you also check the suspensory region or hock region in the right hind, given that there was some lameness at times, or did you feel it was all from the left side?
No, we always examine both hind limbs imaging wise. If you've got one hind limb, we always compare with the other hind limb. This horse, we blocked both hind limbs were contributing to the problem. So we imaged both hind limbs. So we're very similar changes in the suspensory ligaments and the adjacent structures on both hind limbs.
Okay, awesome. Thank you. I have another question here that I want to answer, and this was emailed in, and I actually thought this was a really good question, and it's not about the case. There was someone asking, do you have to be good at lameness to come to the workshop? And my forthright answer to you is no, because everybody is here to learn. And really importantly, we recognize that there's going to be different levels of skills, experience, and expertise in the participants. We are going to meet you where you are at. We're not going to come in and start talking to you going really high level. If you're at that high level, that's fine. We can manage that because it's a small group and because we have so many tutors. But it's really important for you guys to know that we're going to be meeting you where you're at, because everybody has got to start somewhere. Everybody has got their day one, right? And some people on the day 100 or a day 1,000, everybody has got a day one. So you don't have to be concerned about that. There's some names on here. I'm actually really looking forward to seeing you guys. Heather, I know that you're registered and coming, and Tamara as well, and probably a few more people that are on here. So if you are interested in the workshop, I've popped the link down in the chat. Go ahead and have a look at it and work out if it's right for you. We will be closing them off when it fills up, because it's not a matter of if, it's a matter of when. And any questions, you can just email me or send us a Facebook message on the Facebook group. Very lastly, for the members of the Lameness program, we've got our next members meetup on my Monday, which will be Sunday in the US, and I'm pretty sure it's Sunday in the UK as well. Is that right, Dr. Dyson? So we've actually got a really interesting case to discuss, which will be pretty cool. Okay, I think that's it. We'll draw a line under it now and wrap it up. Thank you, everybody, so much for attending and being here today. Congratulations again, Miranda. And Dr. Dyson, thank you so much for presenting yet another fabulous case with huge amounts of insights and learnings for us all.
Great. Good to see you all.
Okay, thank you, everybody. We'll see some of you in person next month in Ocala, Florida, December 5th, 6th, and 7th. Love to have you there. Okay, have a great day, everybody. We'll talk to you later. Bye.
Bye.